Hi, good afternoon. My name is Antoinette Henry. I'm a laboratory technician at Joseph and France Hospital. And today I'm speaking about urinalysis. So, from your general knowledge, what would you say urinalysis? What do you think urinalysis entails? Anyone?
Urine. Examining urine.
Anything else? No?
To get a diagnosis.
Okay. So you get a diagnosis, and like, why would the doctor send you for a urinalysis then?
Because whatever complaints you come with.
Like what complaints would trigger the thought for you to think, okay, you know what, let me.
Well, some people, maybe upper males, maybe have bone in the urine when they pee.
Okay.
And some people, as I hear people saying, because sometimes you might tell somebody, maybe even an older person, you're back hurting your body.
Mm-hmm.
And they will say, girl, maybe the kidney, go check, go get your urine check, like that.
Okay.
Maybe because while you're presenting.
Yeah.
Check the amount of protein in the urine.
Yeah, that's a good one. So, urinalysis goes way back to about 6,000 years ago, where laboratory medicine they practiced. They thought urinalysis was the primary diagnostic tool for patients. So everything they did always fell back on that. This method was called uroscopy back then, but they don't refer to it as that anymore, so it's called urinalysis now. So, when do you get tested? Like, what would prompt you to want to get tested? You personally, why would you go to the doctor? If you go to the doctor, what would you explain to him or her? Anyone?
The same thing, because you're presenting with signs and symptoms and you want to know what's causing it.
Because sometimes we would go on Google and
you see things too.
And see certain things. It's like, okay. So the main reasons why we actually test the urine is some people might experience abdominal pain, and back pain, like what you suggested. They urinate frequently. Pregnancy checkups, a general checkup, you go to the doctor early in the year just that, you decide, okay, I need to do a checkup, so a urinalysis will be included. But persons don't take urinalysis as serious as the blood tests that you perform. But in actuality, when all of them come together, it helps. It's a really big help, because something you might see in the urine will cause you to request a CBC, a complete blood count, or a comprehensive panel to check your renal, liver, etc. So another reason why we would test persons is if you're getting admitted to the hospital and you have to do the full workup now to make sure that everything is how it should be. How is urine collected? Any nurses in here?
Specimen bottle.
Okay, say a person, they have a urine catheter. How would you collect that? Because I'm not too familiar with the catheter process. The collection of the urine from the catheter.
The first specimen drain either in the urinal or whatever, and then you use the middle portion because.
Okay, yeah, that's the best way to do it, because the fresher the urine, the more accurate the results would be. So for us, we require at least 1 to 2 ounces of urine, which is approximately 60 mils, which would be about here. I don't know if you could see. So Patients are instructed sometimes to collect a clean catch, a midstream urine, where they would clean first. Women, you clean the area from front to back. Males, they clean the tip of the penis, and you pass some of the urine into the toilet first, and then the midstream, hence the word MSU. You would utilize that sample, and then you pass the balance into the toilet. That sample is required for not just urinalysis, but for the urine culture. The urine culture, we actually use that to check persons if they have a urinary tract infection, yeast infection, etc. So, yes. I'm going fast now, why? Let me see. So we collect, sometimes we request a morning sample, a random sample, 24-hour urine sample, and yeah, that's pretty much it. Sometimes when you really need a sterile sample, it's the suprapubic, I think, you would use the needle to inject into the bladder, and you would retract the urine. That's when you're really in need of a extremely sterile sample. So, what are we actually testing for when we're looking at the urinalysis? It comprises of a combination of physical, chemical, and microscopic tests. So it's done in 3 phases. There's the visual exam, there's the chemical exam, and then the microscopic exam. The visual exam is where we actually look at the color of the urine, the clarity, whether it's slightly cloudy, turbid, clear, colorless. Colorless would indicate that the person may be a little bit too overhydrated, because sometimes, you know, the doctor tells you you're going for a urinalysis and you want to drink a lot of water. But in actuality, you actually messing with the results right there, because we won't find anything. We'll just find a few cells, a little bacteria here, and yeah. So then, to you know, not to me. So the urine empty, but that's when we overhydrate at times. So, wake up. Oh, I don't know if you can see right here. So, clear would be when you're overhydrated. A bright yellow or orange is a high chance that you're a little dehydrated. Yellow is normal, but normal yellow for me might be different for you. So if your normal yellow is a little on the darker side, as opposed to mine is a little on the brighter side, it's fine. Cloudy, that's an indication of dehydration, urinary tract infections, and a possible kidney stone. Dark brown is sometimes there's a possibility that you overexerted yourself with exercise. So you would, it causes like an overload.
Maybe different medications too.
Yes, I was actually getting to that. Some medications would actually make the urine a little too bright yellow or dark. Some multivitamins too. So, and red, that would be an indicator of a few things. Maybe you had some beets, a little too many beets to eat. The females, maybe you just started your menstrual cycle or you just finished. And for the males, it might be an indication that you have an enlarged prostate. So it's a lot of information you can actually get from just a cup of urine. Sometimes it's a little underrated, but when you actually dig deep into it, you get a lot, trust me. So the kidneys, our kidneys are responsible for producing the urine. It filters out the waste, it regulates the water in our body, and it preserves the electrolytes and proteins that can be actually reused. It forces unnecessary elements in our body to be removed, because that's its job, to get rid of things that don't actually belong in our system. So as I said, the visual exam, you deal with the color and the clarity of the urine. The chemical exam, we cover the test strips, the dipstick. Sometimes you would do that at the doctor's office. The dipstick, it actually covers about 9 substances. So what we actually do is the 9 substances, we correlate those with the actual microscopy. So after we do that and we examine it under the microscope, we would back check to see, okay, if this person's pH was this particular value, you would see crystals, or you'll see epithelial cells, or it varies. Let's see. Spoke about that. So the chemical exam, specific gravity, that measures, that does catch me every time. That measures the concentration of the urine. So it ranges from 1.000 to 1.035. The higher the number, the more elements are dissolved in the urine. Closer, 1.000 will be water, plain water. So if you bring a urine and I use a dipstick and I get 1.000, there's a high chance that that wasn't urine. Maybe you passed a little, you added water. So there's a high chance that because that's water, pure water, nothing in it. But for when you get to like 1.035 is when you would have a high amount of substances dissolved in the urine. An increased number would indicate dehydration, and a decreased number would indicate diabetic renal failure going down there. That's a big jump, but say so the normal number would be about 1.010. Yeah. Okay, for the pH now, the pH is usually acidic. It should be acidic, but it can range from 4.5 to about 8. The kidneys actually are responsible for maintaining the acid-base balance. So it shouldn't be too alkaline and it shouldn't be too acidic. Some substances will actually precipitate, and that's where it will form crystals. Sometimes there's a high chance that the precipitation occurs during the process of the formation of the urine, and that's where we would actually get kidney stones. So just before it passes, like it's produced by the kidneys and it's formed there, which is why doctors will tell you drink more water. It helps, because the precipitation of the elements, that would really mess with you. Bilirubin is tested as well with the dipstick. You're not supposed to find bilirubin in your urine unless there's a serious problem going on. Because actually it is a waste product produced by the liver. So it would indicate 1 or 2 things: liver disease, hepatitis. And sometimes the babies, when they exhibit jaundice. So doctors now they would request a liver panel if they actually received a positive bilirubin and a urobilinogen. The urobilinogen would be positive because it is formed in the intestine from bilirubin. So that would actually indicate liver disease, cirrhosis, viral hepatitis, those kind of diseases. The next one will be protein. Protein now is a rough estimate of albumin. Albumin, it takes up about 60% of protein in the blood. So if there's an increased amount of protein, it's called proteinuria. Proteinuria, once it's seen in the urine itself, the dipstick, it indicates that there might be some cast, some urinary cast. And I have a picture to actually show you guys how the different elements look in urine. So for microalbumin now, we actually only test for microalbumin when the patient has a history of diabetes and hypertension, because it is used to actually help detect early kidney disease, because those persons are more prone to kidney disease as opposed to a more healthy person. Okay. Glucose. Glucose is not supposed to be in the urine. So in two cases where you would find that is if the person is diabetic, or if for some reason pregnant women, actually, that's where gestational diabetes comes in. Sometimes they would produce glucose in the urine because they develop gestational diabetes during their pregnancy. So yes. Any questions so far? Anything?
What about when the urine like have a scent, like fishy quite a scent?
Yes, I was getting to that. The urine, when it has a fishy scent, it could be a few things. The person might have a white blood cell, like an infection, an inflammation, or they could have the parasite Trichomonas vaginalis. It's usually found in women. We find it in the urine for women, because the men, they don't indicate any symptoms, and you wouldn't find it in the urine so easily because it actually dwells in the canal, the vaginal canal. I actually have a video to explain that. So it could be a number of things for this scent. Most times it's because the person has some form of infection, and that's when culture is requested in order to narrow down what type of bacteria is actually causing this, where they could actually know what antibiotic they should use for the patient.
That's where the CNS come in.
Mm-hmm. So when you request a urinalysis, and a CS, the urinalysis now, you pretty much you're trying to find out what's in there. Some doctors, they request it one time, but if you get back a urinalysis and it's showing a lot of white blood cells, red blood cells, bacteria, one too many things in the urine, they might or they might not request a culture and sensitivity. So for the culture and sensitivity, what we actually do is we take a sample and plate it onto agar, and we let it grow for a few days, and then that's how we would figure out in between there what type of antibiotic, what type of bacteria first, and then what type of antibiotic would be susceptible. The bacteria will be susceptible to the antibiotic used. So that's where they would make the recommendation. This antibiotic would be better than this one. This person, they don't respond to this antibiotic as well as this other one. So it's a bit more complex than the urinalysis per se. So I don't know if I answer your question. Ketones. The ketone is actually on this strip as well, and it should not be in the urine unless maybe the person is diabetic. I don't know if you guys are aware of persons that are doing the keto diet. So they eat purely fatty foods, etc. And they have to be in a particular, in ketosis in order to burn fat. So instead of using up the glucose, it will start to use up fat. It's a diet. It's a new diet. Yeah. So what persons would do, they would get the urine strips and they would check the urine to see if they're in ketosis, which is when they would produce the ketones. To each his own. Yeah. Blood. An occasional RBC might be seen in the urine, but it shouldn't be, because if it's too much, then you'll have to further investigate as to why is this positive, why are you seeing RBCs, because it's hematuria, but it might be for a few reasons. As I said, the person might be on their period, they did some strenuous exercise, etc. So leukocytes, also known as white blood cells, few is normal. Like if you do this stick, the dipstick, and you get a trace, that's normal. But when I don't know if you guys could see this, when you get to about 1+, 2+, and large, which is about 3+, that's when you start to get a little concerned as to the person might have some form of inflammation or infection. So this is how the dipstick, this is the dipstick itself, and these are the substances that are tested. Stop doing that. So it's leukocytes, the nitrite, urobilinogen, protein, pH, blood, the specific gravity, ketone, bilirubin, and glucose. For the nitrite would only be positive if there's an excess amount of bacteria, because bacteria it turns nitrate, which is naturally occurring in urine, to nitrite. So that's an indicator as to the person has something else going on. But sometimes the nitrite isn't positive, but that doesn't mean they don't have a urinary tract infection. So further investigation still needs to be done in order to rule out any form of infection. So that's the chemical aspect of things. For the microscopic exam now, what we do after we get the sample, there's a reason why we ask for approximately 60 mils, because it's about 10 milliliters we need to actually perform the process. So we would pour it off into this. It's a falcon tube, and it's between 10 to 12 mils, but preferably 10 is fine. But if we start going down to 4, 3, it might be a little bit too concentrated. So the test results might be a little inaccurate because they would be saying that this person has a lot of, or you might not see anything at all. The bacteria would cloud everything in the field. So it's always asked to have about 10 mils. So what we do, we take this, we pour it off in this. We spin it in this centrifuge for about 5 to 10 minutes. After which we would take it out and we would gently pour off the sediment what we actually looking for would settle right below here. We call it the sediment. So that's where the goal gonna be. So the supernatant, which is the liquid that settles to the top of the sediment, we pour that off because we don't need that. So then now after that, we will take it and mix it with a pipette and then place it on the slide, on a cover slip, a thin piece of a glass, and put it on the microscope, and that's when the magic that's when the magic happens. So that's where we would see things like the red blood cells, white blood cells, epithelial cells, which is the skin cells. Because remember, we sleuth off cells every day. So that would you will see that. Mucus, crystals, bacteria, and something called urinary casts. I keep doing that. These are epithelial cells. I don't know if you can you see? So in the background you might see 1 or 2 white blood cells, and the bacteria it's really small. But if it was a live slide, you would actually see the bacteria moving in between. Let's see. So, okay. So for this, I could do that? No. There's red blood cells, white blood cells, and yeast cells. The red blood cells are the the circular ones. You see it? The white blood cells are the ones where you actually see, it's like you're seeing some sort of matter in it. You can see it? And then there's the yeast. The yeast cells now, there's a lot in this sample. These you would call budding yeast because they're joining on together. When you actually see something like this, it would indicate that the person has a yeast infection. These are branching yeast cells. So there's budding yeast cells and there's branching. It depends on how long or how old the urine was as well. So, and then you heard me speak about casts. You see casts, you get an indicator that you have casts in your urine with the amount of protein that you see on the dipstick sometimes. Sometimes yes, sometimes no. Hyaline cast, you could barely, as you can see, you could barely see it. It's like a faint, but it's shaped like it's a tubular kind of shape. It's like this, but you could barely see it because this one has fat. This is a hyaline to fine granular. Then there's the cellular ones. Sometimes with these, the red blood cells, the white blood cells, they attach themselves to the cast because there might be something else going on with the patient. So, and then these are crystals. Each crystal it depends on the pH of the urine. So these would be the normal ones you might find: triple phosphate, calcium oxalate. These are the ones I would see mostly: triple phosphate, calcium oxalate, uric acid, amorphous. The abnormal ones, there's bilirubin, cholesterol, leucine, and cysteine. I haven't personally seen cholesterol, leucine, and cysteine. I saw bilirubin crystals before, though. That's when the patient might have an extremely high amount of bilirubin in the urine. So then, this is just a little table. It breaks down the name of the crystal, the pH, whether it's acidic, alkaline. Sometimes the crystals, it goes either way. So it's alkaline, you will see it. Acidic, you will see it. But for some, you will see in acidic urine and still neutral urine. So you will have a pH of 7 and you might see tyrosine. So there's that. Okay, so earlier I spoke on trichomonas because trichomonas is a parasite. So yeast, trichomonas, white blood cells, red blood cells, bacteria are found in the urine. This is how it would actually, when you actually find a live one under the microscope. So I don't, if you watch closely, you'll see something looking like a tail right here. That's called the flagella. In the lab, you say they're walking up. So this one is really, really active. You see it enjoying itself. These, they actually cause the foul, fishy odor and the itching. It's like a constant itch you have and you can't scratch it. So you see this one has a lot in the field. Yeah. And it usually dwells in the canal, the vaginal canal. So a male might have it, pass it on to the female, but you'll easily detect it in the female as opposed to the male. So he will never know that he got it.
So passing the urine can flush out both?
She passed out some. So so she passed the urine and some get catch, and some we might detect. You have to look closely and detect them by their characteristics, how they're supposed to look. Because by the time we get the sample, it already died. Some, like this one, you'll find a good amount in there having a party. So, but, so, yeah. This one. So, Trichomonas vaginalis. I mean, a lot of people don't actually speak about it. It causes trichomoniasis. So if it's okay with you guys, I'll play a little clip so they'll actually explain the whole.
Trichomonas vaginalis is responsible for a sexually transmitted infection known as trichomoniasis. And as we'll talk about in a minute, the symptoms mainly occur in women in the vagina. Now this STI is not caused by a bacterium, but rather a protozoan, which is a more advanced form of microorganism than a bacterium. And this protozoan specifically is a parasite, and it exists mainly by eating cells that they destroy, so eating cell fragments. And this protozoan uses these cell fragments or these pieces of cells for nourishment. Now they typically have a pear shape to them, so I'll draw this pear shape here. So this is their body, the cell body. These trichomonas, or you can also refer to them as trichomonads, have one cell to them, so this is the one cell pear body. And they move around because of these protein strands, these whips that they have, that are called flagella. Flagella. And finally, one of the other things you might see if you take a look at this guy under a microscope, as we will in a minute, is the nucleus. So here's the nucleus. Now because trichomoniasis is a sexually transmitted infection, we have to consider the mode of transmission, or how does it commonly spread from one person to the other. And as the name sort of suggests, this occurs only through vaginal sex. And what makes this infection very interesting is that the trichomonad protozoan can't survive anywhere else. So they can only live within the urogenital tract. Now this means they can live within women, like in the vaginal tract or in the urethra, or they can also live in men. But the tricky thing about that with men is that they rarely have symptoms. So they're asymptomatic, which means that they're carriers of this infection. So they're asymptomatic carriers that can spread this STI to women without even realizing it. So if we take a look at this woman right here, and I've drawn her urogenital tract, so we're taking a look at a sagittal section, or if we chop them in half, from head to toe down the middle through the legs, you can see here is the bladder that leads out the urethra. So here's the urethra, and here is the vagina. So the vagina. At the top of the vaginal tract is the cervix over here. And this part that I won't label for our conversation because we won't be talking much about it. This is the anus that leads up to the rectum and the rest of the GI tract. So if a woman is infected with trichomonas, they're going to spread into the vagina and spread up the vaginal walls. And we can take a look at this on a larger scale here. Here are the vaginal walls and we're leading up to the cervix. Let's say that the trichomonas is climbing up the vaginal tract using its flagella right here. I'll draw these green. And it latches on there. It'll use this type of mechanism to whip itself upward, and in doing so it causes stress to the cell membrane that over time, as I'll show up here, causes the cell to die, producing fragments that used to be the cell that are scattered into the vaginal tract and eaten up by this parasite. Now your immune system will recognize this, and in response to the trichomonas, white blood cells will be sent here to combat them and release toxins and try and engulf them and eat them to stop them from killing cells in our body. And as a result of this, we will get inflammation. Inflammation meaning more cell death in response to the ones that have been affected by the trichomonas, as well as a fever and other systemic responses. And that causes irritation. If we have white blood cells fighting the trichomonads within the urethra, you can get urethritis, which will cause pain when you urinate, and that's referred to as dys, meaning painful, uria, meaning urination, so painful urination. The same thing happens up here with the vagina, as well as with the cervix, because you can get vaginitis, as well as cervicitis, cervicitis. Irritation of these two will then make sex rather painful, causing what's referred to as dys, again meaning pain, periunia, dyspareunia, or painful sex. And as this battle continues, you'll have more dead cells, dead white blood cells, dead protozoa falling through the vaginal tract out, producing frothy green discharge. And this also has a characteristically bad smell, or it's malodorous. Over time, this inflammation can actually cause some pretty bad effects as well. In women, especially those that are pregnant, chronic irritation or long-term irritation can cause them to deliver a baby earlier than they should. So that leads to preterm labor. Also, long-term inflammation can cause irregularities in cell formation or cell division at the cervix, over time producing cervical cancer. The idea, though, is that because women tend to have symptoms, we will catch the trichomonads earlier on and treat them, as we'll talk about. In men, there's a greater concern, though, because they're asymptomatic. So one of the things that you can get with chronic inflammation is prostate cancer, which is why, as we'll see in a few minutes, why it's important to treat the symptomatic patient as well as their asymptomatic sexual partner. Now, let's move on and talk about how do we diagnose trichomoniasis? Well, there are two main tests that we can employ. The first is what's referred to as a wet mount, which is exactly
that's what we do.
Like. A swab of the vaginal tract. So you take a swab, let me draw that swab right here. And if we swab the vaginal tract, we'll get a sample.
You can actually find it in the urine using the urinalysis, or you, as he said, you could actually do a swab. And either way, you can find it. It's also seen in pap smears as well, in the stain. So it's a little tricky, but you could actually find them in pap smears as well. So, everybody okay? Okay.
Of cells, mucus, and hopefully some of the protozoa as well. From there, you put the sample on this slide. So you put it on this slide. So there's our sample. And you take a look at it under a microscope. and this is what you'll see. There'll be some squamous cells, so these simple squamous vaginal epithelial cells, as well as these two guys, which are actual microscopic views of these trichomonads. And I think you can see here there's the nucleus, the pear-shaped body, and the flagella that are present here. The second test you can do is a culture, or just try and grow out the trichomonads on a petri dish. So here's our petri dish over here, and I've smeared our sample from this swab right there, and we'll let it grow over about 5 days. Then what you'll see here are these trichomonad colonies that are growing on this petri dish. Okay, so now that we've diagnosed trichomoniasis, how do we treat it? Well, here too, we're going to use antibiotics, and we can use the culture up here to determine what antibiotics the trichomonads will be sensitive to. So say let's put antibiotic number 1 down there, and antibiotic 2 up here. Over time, we'll see that antibiotic 2 wasn't very useful. We still had these trichomonads grow, even though we had it on our petri dish.
So this same thing applies.
Whereas down here, antibiotic 1 created this space where no trichomonads could grow. So that way we can have our culture determine what antibiotics the trichomonads are sensitive to. So we can have our culture determine sensitivity. And another important thing about treating infected patients with trichomoniasis is that their sexual partner should be treated as well. Because remember, if their partner was a male, they may not have any symptoms, but are at risk for developing diseases down the line. Now, what if we wanted to prevent trichomoniasis altogether? How do we achieve prevention? Well, the trick here, like most STIs, is to block transmission. And we do that by limiting the amount of direct contact during these modes of transmission. So in this case, during vaginal sex, use of a condom, so condoms, can greatly reduce the rate of spreading trichomonads potentially from an asymptomatic carrier to a susceptible patient. And because Trichomonas vaginalis can only live within the human urogenital tract, if we treated everyone that was carrying this parasite, we could eradicate the disease from the planet.
Okay. Any questions on that? So you see how important urinalysis can be. So something as simple as passing a urine, you can actually detect certain things or can prevent problems that will happen further down. Because trichomoniasis, it can lead to so many things: the prostate cancer, cervical cancer, all the itis, the inflammations you could possibly get. So one sample, you pass the sample, the lab technician looks at the sample, detects that there's trichomonas, or per se if the doctor suspects it because the patient is experiencing certain symptoms that would lead to him thinking that, and he would ask for a culture or whatever, you could actually prevent a whole line of problems. So, but persons don't actually think about this when you perform a urinalysis, right? That wouldn't cross your mind, would it?
I about already. I wasn't out here from the beginning of the video. That's sexually transmitted?
Yes.
Oh, okay.
Yeah, it's an STI.
Oh.
And it can only live in the vaginal, both canals, the male and the female. The difference is the female, you can detect it a lot faster as opposed to the male, because he won't show symptoms and there's a rare chance you'll pass it.
So from the time a female diagnosis with that, she is to get medication from her partner as well?
Mm-hmm.
Our partners?
Yes, it's advised.
Mm-hmm.
So,
Trichomonas vaginalis is responsible for a sexually transmitted infection known as trichomoniasis. And as we'll talk...
So that's a tricky one though, because the woman won't know if it's the man she gets it from. She presenting symptoms, so
She will know, but the woman will know who she gave from.
yeah, that was saying because she presenting the symptoms, so she I mean, if she have multiple partners, then if she multiple,
If exactly.
yeah,
So, but if she had
she
one,
wouldn't know.
she ain't gonna know who she get it from.
So she don't know who to go approach and say bye.
No. And it gives you that itchy. They said it gives that itchy.
Oh.
Some people say are feeling like they want to have sex. So that's the problem because if you're feeling that, you have sex, you transmit it. So
So lady can give the man?
I would assume so, yes. But it from my knowledge, transmission is mostly from the male. Yeah.
So if they're going to keep multiple then they don't know who they came from.
Yeah. Okay. Yep. All from a urine, right? This is a little.
Welcome back. We're going to be doing the manual microscopic of all of these specimens that we just did on the Criterion 2. The hard part about this is the one that's in the Sundance tube. It needs to be in a conical vial like these guys, and so there needs to be, a place where everything can settle and make a pellet, as you can see down there. And what we're going to do is we're going to take the urine, the supernatant, off after we centrifuge it down to 1 ml. And then we're going to analyze it on the microscope. I'm so excited. Okay, so we're going to, again, invert like this. Okay, we can pour it off into the conical vial. We need 10 to 12 mils. As you can see, it is yellow and clear. Okay, you can see right through that puppy. And let's see, we have just under 10. That's going to be okay. You get what you get and you don't throw a fit. All right, so I'm going to get a cap. Get a little cap. Hopefully that's going to sit nicely in this guy. Okay. Sometimes these caps don't work.
We actually have the screw ones. I'll just show you. This is a screw it on as opposed to that.
Okay, so we're gonna put these guys in the. I know that looks horrible. We're gonna put them in the centrifuge. Okay, but what we need to do is we need to make sure that our centrifuge is at the right setting. So here we have urinalysis is 1800 for 10 minutes. Okay, so I'm putting them in first, and then you want to balance the centrifuge, obviously. You want to put them into the buckets that are big. Okay, not the little ones for the blood tubes. So if you see, I need to have a balance here. And so I got a balance. This one's just water. And when we balance our centrifuge, we're going to make it so that it goes across the rotor, so that it's balanced across the rotor. Okay, here's the rotor, and it needs to be balanced across the rotor. So we did that. Okay, that comes down in very high force. All right, so now what we're going to do is we're going to program our urinalysis setting. Okay, so we're going to go with speed. Speed is going to be 1800 RPMs. We can just press the down button. Oops. Goes up by tens. Okay, so 1800, and then we're already at 10 minutes. Okay, so we can go ahead and press start, and it's going up and it's starting. All right, I'll get back to you when it's done. While we're waiting for that to finish up, I want to set up my microscope with you. Okay, so what we're going to do is we're going to set this microscope up and make sure that it's ready to go. All right, what we're going to use, we use a specific kind of slide for urinalysis when you do the microscopic. It's the Eurosystem.
And you can actually count more at once.
Deci slide, and what that means is that we have 10 wonderful windows here of where we're going to put the urine specimen. Okay, and notice, kind of like a hemocytometer in regard to, you put the liquid in there, it's like a wet prep kind of deal. Okay, you would not use this for wet prep for stools or anything because the stool's too thick to put it down in there. So you would use a regular slide and a cover slip, but this is just for urine. And so what you do is you spin the urine down, as we're doing right now in centrifuge, and you take the supernatant off until the specimen is down to 1 mil down here. And everything that's down here is going to then be resuspended, and we put that resuspended suspension in here when it's on the stage, the microscope. Okay, so when you're moving your microscope holders, the pins, you want to make sure when you turn it on, the beam of light is going through the window that you want to use. Notice that if you do use windows 1 or 10 or the ones on the periphery, especially the ones over here that are on this pin, sorry, oh man, come on. It makes it so that it's kind of difficult to get it so that it's not going to fall into the microscope. So you might want to start with 2 if you want. Some people go through and they mark an X on ones that they've already finished. You don't have to do that, but it's always an idea. You do not go on oil with this one, okay? So you just end up on 40 or 400, if you count your ocular. And that's where you're going to end up doing all of your counts and your visuals. Okay, you start off at 10 first, and you're going to scan the entire slide. Okay, you're going to look at the periphery, because if you do, you might find things that you don't see when you're counting. Okay,
Some things actually,
that you want to know is
some things would actually go to the corners of the slide, like casts, and so you have to be thorough and count as many, because this, as small as it is, it's divided into little squares. So when you look into the microscope, so for instance this one, she's looking at this one, when you actually look in, you'll see a whole bunch of little squares. So that's how you will count, like that's how you average how many red blood cells you saw, white blood cells you saw, bacteria, the casts, the urinary casts, and anything else that you actually see. One is red on the high power field, and one is red on the low power field. The low power field ones are for the larger ones, like the casts, epithelial cells, etc. The high power field, because they're a bit smaller, would be the red blood cells, white blood cells, those things where you have to quantify. We report it, but before, years ago, you used to report it as few, moderate, many. Now it's 1 plus, 2 plus, 3 plus, 4 plus. So a report, you might get back a urinalysis report, and you will see RBC 1 plus, WBC 3 plus, epithelial cells, and that's when you actually quantify. So it's 0 to, so you get like 1 plus. So it depends on what you're actually looking for, or what you actually find, that is. So I know sometimes you might, as nurses, you will see the report and you look at it and you will wonder, what is this? What does this actually mean? So you would see RBC 1 plus, and it will have HPF to the N. That's high power field. LPF, low power field. But the form is a little bit different now, so it's a little more detailed. So it actually breaks down. There's a section, because now with the dipstick, we actually have a machine that does that. I think it's the Clinitech, you call it. So you dip the stick in the urine, you tap it for the excess urine, you place it on the little, there's a, I think I have an example. There's a little slot that slides out, and then it will slide back in, and you will start the process. So you will record whether the urine was clear, cloudy. You will indicate on the screen, and then after that you will allow it to read each one, because each one is under a timer. One you might have to read for by 60 seconds, another is by 5 minutes. So the machine actually helps with that, because human error. We might look at it, as soon as we dip it, take it out, tap it. Okay, no glucose, no ketones, no this, no that. And 2 minutes later, the person actually had white blood cells. It actually had red blood cells. So it actually helps, it speeds up the process, because after you're finished with all that, you still have to go on the microscope and read. And sometimes the workload is heavy. Sometimes we will get 30, 40 urines a day. And imagine you reading those individually on a microscope. It's the same with stools. Sometimes stools, and the process is a little more, I wouldn't say complex, but you will get average 20, sometimes the most 25, and that's stools there, and you have to each one. So we might say, oh, it's just a urinalysis, you could do it, which is why we have a cut-off time at the hospital, 11, because by that time they're already processing the samples, and it's best that you get the urine or the stool or whatever else by a certain time to the lab. Otherwise, sometimes when the urine sits for too long, it would start to, if it had crystals, they'll start to disintegrate. If we had whatever, if it's not at a particular room temperature either, that's problems too. So you have to be careful. There's a reason for rules. There's a reason why certain things are put in place, and sometimes we, as humans, we would think that it can be adjusted, but for person's health, for your health, think about why do they have that particular reason for this. Oh, it's only 11 past 10, 11. You could take it. This time the person up there got 20, 25. I'm gonna make 26. So the
sometimes maybe it is so long wisdom because nobody there to take it down for you, and then
yeah, I understand. It go both ways. It's all a matter of staffing and all that, but that's a story by itself. So let's see if it has. But you get the gist, right, with this.
Back, we're going to be doing the manual microscopic of all of these specimens that we just did on the Criterion 2. The hard part about this.
Okay. Let's see. I think I have one more. Oh, there you go. So, any questions? Anything was unclear that needs to be clarified? No? Really? How was that clear?
Is the super pubic sample done here?
You know, when I was doing the research, I was wondering, do they do it? You guys do it? The doctor?
Yes.
Okay. Yeah, I wasn't too sure about that because I know about it, but I wasn't too sure if they actually did that. So, anything else? So, as you can see many things in just a drop of urine. Crystals, casts, blood cells, white blood cells, bacteria, mucus. I didn't talk about mucus. Mucus is actually a normal component of urine. So if you see a few, it's okay. Especially if maybe for the females, the vaginal discharge on ovulation period, you would find those. And it's faint. I didn't bring a picture of that. It's a faint. You can barely see it. You have to adjust the light to find them sometimes. Mucus. It's mucus. It's mucus. It's mucus threads. It's different. It's how should I explain it? Because the pus would be, what we call pus is the white blood cells, the PMCs. So, but the mucus is like the regular discharge we have. It's something that you would normally find in urine. Just like normal crystals, you'll find uric acid crystals. Maybe you didn't drink enough water that week, so there's a few crystals in there. But when it gets to a point where it's in excess, that's when you have to look out for kidney stones. And to pass a kidney stone, I've heard is yeah, some terrible pain. So drink your water. You can be overhydrated, with anything you could actually have too much. So drink the amount of water. There's actually, you can actually find out how much water your body requires by a calculation. You find it on Google. It's calculated according to your weight. So most persons about 3 liters a day. 3 liters. That's 3 liters average would be, the big island purified. Not the big one, the tall one. About 3 of those, 3 to 4 of those. That's a lot of water, But just especially with the heat, because you stand a chance of getting dehydrated, and you see what can happen if you're dehydrated. And diabetes and urinalysis, that's one of the tests they use to monitor how well they're controlling their diabetes, the urine test. Because as a diabetic, you'll be passing out the glucose in the urine. It shouldn't be, but you're diabetic, so that's an indicator as to, maybe you ain't controlling it the way you should be controlling it. So I think I covered everything I could. Yeah, I bet you the Chicamonas was a little, well, not this lovely lady right here, she asked me about it. But that's something that people don't talk about. We in the lab, we used to see them, but the layman wouldn't know. You could get a parasite and you could pass it out in your urine. It's a cause. It's
correct. When you do a urine test, you check.
The thing is with the urinalysis, once you're on the microscope, sometimes when you would see it, sometimes it would be a little more difficult if they aren't alive.
Okay.
It's mostly identified by the flagella, the little tail thing you see wiggling. But if not, you'll have to actually look for its characteristics, the flagella, the nucleus inside, the shape, the pear shape. More experienced persons would find that. So, but if you find it, you report it. At least the doctor know that you have it, treat it, and get that out your system. So, urinalysis isn't as simple as we might think. It's actually, in the olden days, they say it was like a window into your soul. You could find, so you can actually use the urinalysis to find out a lot of things. You should use it in collaboration with other tests. So for instance, as I said, the bilirubin, you do a liver test. You find the bilirubin was positive, you do a liver test. You find the glucose in the urine, you do a fasting blood sugar to make sure the person... No. The doctor would do that, should do that as a follow-up, not just take the urinalysis by itself, because everything in the lab goes hand in hand. Because sometimes you will be in there and you get a blood count, an HB extremely low, and then it would reflect in other tests. So we could actually say this person's HB was low now because this other test indicated something ain't right, something else going on with the patient. So the lab is very important. Let me put that out there.
Thank you for saying that.
It is. It's very important. It's underrated and sometimes forgotten. So, but if there aren't labs, it'll be extremely difficult to diagnose a patient if you don't have results to collaborate with the patient's symptoms. So in my opinion, the doctors, the technicians, health on a whole, nurses, doctors, technicians, everybody should come together and really put in and communicate and cooperate. And because communication is a big thing, and I find a lot of us have a problem with that. So that would actually make a big difference in the health system. That's my opinion.
We agree.
So it's because if the doctor requested, because sometimes another thing too, we might not receive a diagnosis on the farm. So we're running the test and we don't know. Okay, so we don't know. Is this normal for this patient or is it an alarm? Because sometimes you get a HB and HB low, we call it out. Oh, personally anemic. It wasn't on the farm. So
we need to put the diagnosis on the form.
Yes.
And if they're diabetic and you see the glucose, you will know that person.
Exactly. If they're hypertensive too.
Yes.
Because as I said in the discussion, hypertensive, diabetic, both 1 and 2. We perform the microalbumin that actually is an indicator as to whether you're on the path to kidney disease or kidney failure. The result you will get, it would actually determine that or help determine that factor. So as I say, everything is like a domino effect. The doctor will send the patient come to the lab, patient did blood works, urine, whatever else, results go out, doctor diagnose, follow up, because you have to follow up. Because sometimes, okay, for instance, if you would pass the urine, say you pass the urine, that particular day you drank a lot of water, you ate well that week, but yet you were having some form of abdominal pain or whatever. But you ate well that week, because some things you eat would trigger certain reactions in the body and we don't know. So that's why it's good to follow up. we as we don't like to go doctor. So we don't want to know. Some people just don't want to know. I'm fine. If I don't know, I don't know. But it's good because sometimes that will prevent some things that in the long run can actually be prevented if you had only been going to the doctor regularly. So
I have a question about when the doctors tell you, like, you said protein that in the urine and crystals and so. The doctor said I need to drink a little water. That does really help? That would really help? Or you have to do a follow-up after? The doctor remember they tell me drink some more water.
A follow-up would be good. Maybe it's your diet too. Maybe what you're eating causing a little more your kidneys to work a little harder than they should. So as I said, sometimes we don't know. There's a lot of things going on in our body and we aren't aware of. We eat, we drink. Sometimes we don't exercise, sometimes we exercise.
A lot of people are here got complain with the protein and
the crystals.
A lot of people are here saying that.
Sometimes people will tell you if you have maybe a kidney infection, people will tell you, drink some coconut water.
Well,
or cranberry juice.
I personally can't vouch for that, but follow up. You could drink it, and you follow up and see if it's all about cause your body. So if anybody to experiment on this is you. If this doesn't work for you, try something else. I for one believe more in the natural method, medicine. I personally don't like tablets. And because I work in the health field, I personally don't. My sister did. I can't swallow tablet. And so sometimes I would before. But you have to use your discretion, If the pain is really bad or the ache is really, check it out. But if you can drink a little bush and drink a little more water and go walking, maybe once or twice, 3 times a week, and don't push yourself. Okay, I got to do this, I got to do that, and then you overwork yourself, and then you tell yourself you want to do it again. Just gradually make the changes. Like if you're accustomed to drink a lot of soda, okay, if you drink 4, put it down to 1, and the rest is water. That's how I see it. I would pick up drink bush tea than medicine. Sorry, that's just because I was still I'm asthmatic, sinus allergies. So I grew up taking a lot of medication and inhalers and the nebulizer, and so now older I'm not a big fan. Cause you didn't think I had enough of them?
Having a cough and asthma, you should come.
When?
I remember the date.
Okay.
We will let you know.
Okay, so I guess that's it for me then?
Yes.
Was I clear?
Yes.
Huh? What's that? Thank you for being shy.
Very good for being so
Okay. Oh, and this is I forgot. This is the steroid content if you're not aware with it. Familiar with it, sorry. Oh.
Miss Henry, this afternoon,
Hi.
on the behalf of Care Nursing Agency, Sister Blythe, and all of us here, we thank you for taking out your Sunday afternoon and really educating us on urine analysis. Thank you very much, sis. And I'm very proud of you.
Sister?
You stressed me out in the process, sister. You stressed me out. I was getting fed up now.
Hello, get to the point.
You did. You did a wonderful job. And
Thank you.
Thank you.
Everybody.
Oh my God.
Oh,